essentially, I'm coming to the monitoring in the prostate cancer. As we have gone through the diagnosis and come to grade grouping of the cancer, these cases are discussed in the MDT. Then we have essentially three sort of options as a standard, as a monitoring or active surveillance or a watchful wait or a robotic prostatectomy or a radical radiotherapy or other forms of treatments. In the outline, in my talk, I will just go through the definition. There is sometimes a bit of controversy and the fine line between active surveillance and a watchful wait. So I'll just briefly about that. What's the rationale behind these presentations? What are the criteria we use for active surveillance, the standard protocols currently available, and the evidence, and end with conclusion. So what's active surveillance? It's essentially a conservative management approach where we know that a small group of low risk or a favorable risk prostate cancer patients might benefit from active monitoring, and it mainly avoids a long-term adverse effects on patients' quality of life. I would like to highlight the point that active surveillance is not completely canceling the treatment, it is delaying or monitoring them actively. On the other hand, watchful waiting, it's essentially a treatment offered for men with a limited life expectancy. So these are the two essential differences between the active surveillance and watchful wait. Briefly, on a tabular manner, the active surveillance is, its intention is to curative, and for the watchful wait, it's more of a palliative approach. There is a predefined schedule of follow-up in the form of DRE, PSA, rebiopsy, MRI for active surveillance cohort. But on the other hand, for a watchful waiting, it's patient specific, and there is no predefined decision for that. Generally, the life expectancy has to be over 10 years for active surveillance. If there is a less than 10 years, and probably what we talk is around 5 years life expectancy is taken for patients to be put on watchful wait. And the main aim, as I've outlined, it's to reduce or minimize the treatment-related toxicity in both the settings. The watchful wait is applicable for all group of patients, and on the other hand, the active surveillance is only for low-risk patients with the prostate cancer. What's the rationale? We know that low-risk prostate cancer has a very or a low or a minimal risk of progression, and almost there is no risk of metastasis. Or in a large Hopkins trial, there was 1 in 10 to 15,000 patients where there was metastasis in a Gleason 6 prostate cancer. On the other hand, we know that the treatment, what we offer, either robotic prostatectomy or radical surgery, although they have had a good evolution over these years, but still few patients can have a life-changing side effects. So coming to the point of natural history, why this was offered as one of the treatment options for low-risk prostate cancers. So we know that there is a significant treatment dilemma for prostate cancer patients. The main 2 points for that is the heterogeneity of prostate cancer, that Gleason 6 behaves entirely differently compared to Gleason 9 prostate cancer, and multifocality. In the same prostate gland, they could have a Gleason 3 to Gleason 9 prostate cancer. So these are the things which will guide us to choose a different treatment options for a different type of cancers. Gleason 6 cancer is has innocent genetic features and no risk of metastasis at all. So in the absence of high-grade cancer, there is currently very little indication for treatment in most of these patients. This is standard. I think most of you have seen this way back from 2004. It clearly shows that for grade group or a grade 1 cancers, the survival from the time to diagnosis up to 20 years is very low. On the other hand, is grade 3 is significantly high. And if you come to the T0 to T1, T2 palpable tumor, it's a similar picture. So that's the gist of this. A 20-year follow-up of patients where around 767 patients were included. The prostate cancer mortality in the first 15 years was 33 over 1,000 person years, and men who are over 15 years follow-up, there's 18 per 1,000 15 years. Men with the low-grade tumors have a minimal risk of death in 20 years. On the other hand, the men with the Gleason 8 to 10 cancers have a higher risk of death. So that's the reason authors do suggest that low-risk cancer should be offered active surveillance. At the same time, high-risk cancer shouldn't be included into the surveillance protocol. This is again from 2004-5. At that time, there was a Gleason grading 2 and 4 were included, and even 5 and 6. But let's concentrate on patients with 65 to 69 with Gleason 6 scores. If you clearly see the prostate cancer mortality is significantly lower compared to the same group with the Gleason 8 to 10 cancer. This again emphasizes that these patients have a very low risk of progression and mortality. So patients should be offered active surveillance as one of the treatment. Now, what sort of techniques or assessments do we need to make before we put someone on active surveillance? There are several nomograms could be used. The nomograms will help us to assess. One is to what's the risk of from the cancer side of progression and metastasis. Also, we could use nomograms to assess the physiological age of a patient. Then the next bit of the biopsy. So the number of cores, the grade of the biopsy, and what sort of biopsy was it done? Was it targeted, systematic? So all those are essential information before we put someone on active surveillance. Then recently there is some development using an MRI scans and a genetic screening to be added in the armamentarium before we decide about the active surveillance for a patient. If you look at the tools, I routinely use a Predict tool. This is a reasonably established tool where you can add all the parameters, including the age, the PSA, T stage, and whether they have had a BRCA gene, and the ethnic origin is yet to be included. And that will give you a rough guidance about what's going to happen with those 100 prostate cancer men of a similar cohort. How many will have prostate cancer related deaths, how many will have overall deaths, and how many will survive with the conservative treatment. This should give us a rough guidance before we put someone on active surveillance. What are the current active surveillance criteria? Okay, it has evolved quite a lot, but many years, but I think most of the criteria are more or less unchanged, except few additions at the end. So if you look at the main parameters, including the clinical T stage, generally it is agreed that it is T1C to T2. MSKCC and NICE, they usually use a T2A up to that level. Gleason 6 or less, that's a standard agreement. There has been some discussion about very low volume Gleason 3+4 to be included, and we at our center we routinely offer surveillance for even Gleason 3+4, but a very selected patients. And a single core involvement, it has been agreed that less than 50% of this maximum core, and then PSA has to be less than 10, although the abstinence or initial criteria was up to 15 as well. A PSA density, most of them agree that the PSA density should be less than 0.2, but with the recent trend, there is up to PSA density more than 0.15. Again, should be carefully considered whether they should go on active surveillance or should they be offered radical treatment. Currently, the NICE guidelines is more or less the same with the other guidelines, which shows the PSA has to be less than 10, Gleason score of 6 or less, and T1 to T2A. BAUS has included even the core density, core length into the guidance. The European Association has got a similar picture. Now, briefly about the MRI. If you see, this was ASIST trial, which was done, Klotz and the team. It's a prospective randomized multicenter open label trial, mainly for grade group 1 cancers, who are eligible for active surveillance. What it included is 12-core systematic biopsy sampling or MRI with the systematic and targeted sampling. So initially there were 259 patients. They were equally divided into 2 groups. After the MRI, 100 men were included in non-MRI arm and 98 into the MRI arm. The results said that there were fewer men with active surveillance failure in MRI, suggesting that MRI will help us to identify more targeted lesions, and biopsying them will help us to stratify these active surveillance patients more effectively, and the chance of failure will be lower in those group of patients. And the conclusion was that baseline MRI before this biopsies during the active surveillance results in 50% fewer active surveillance failures than less grade progression over 2 years. Although it was a short-term follow-up, but that gives us a good suggestion that MRI to be included. If it is not included before the biopsy, they should, all men with the prostate cancer should have an MRI before they are actively put onto the active surveillance protocol, and the management should be changed depending on what the MRI figure is. I've found very little evidence in terms of biomarkers, but there is a PSA density, percentage free PSA and PHI have got a moderate evidence in supporting active surveillance protocols. These are mainly to include the patients into the active surveillance, not for the during the active surveillance protocol. PSA kinetics, like we routinely use during the active surveillance protocol, but there was a limited evidence in terms during actively implementing or putting patients into the active surveillance calls, and urinary PCA3 and other markers have no evidence in this criteria fitting. What's the standard protocol? Patients who have had an initial diagnosis of prostate cancer, they should have an MRI prostate if they have not had before the biopsies, and depending on that, they may have to have a systematic biopsies if the initial biopsy was a thrust-guided prostate biopsy. During the active surveillance protocol, they should have every 3 to 4 months of PSA surveillance for the first year. Throughout the active surveillance, again, they monitor the PSA kinetics carefully. Previously, DRE was included as one of that every 6 months. Now it has been changed at once at 12 months. And more emphasis has been given on multiparametric MRI, which is usually around 12 to 18 months. And routinely in our practice, if the patients have had a systematic biopsies at the start, and if the MRI doesn't show any significant change at 12 months, we routinely monitor them with the MRI unless there is any change in the risk factors. Following that, after 2 to 3 years, there is just a vague parameters or the criteria, which gives us every 6 months the repeat PSA, and there is no definition about when to repeat the MRI. Those all are dependent on the PSA kinetics and also rectal examination and the risk factors at that point. There are some limitations of active surveillance. As we know that the current active surveillance protocols, unfortunately, have all based on 12-core thrust-guided prostate biopsies. And now we are in an era where we are trying to do more targeted biopsies, anterior biopsies, and So it may not be able to directly use all those criteria which have been based on 12-core biopsies. So biopsies, 12-core biopsies, we know that there is underestimation of the cancer grade in 30% and underestimation of the volume of the cancer in 50%. Then there is a bit of inherent errors with the trust-guided prostate biopsy, what is called a systematic error, where we can't anterior lesion or a transitional lesions are not biopsied, and a random error where, because we have patients who have not had an MRI before, we don't know where the cancer is, and we are just doing the trust-guided random biopsies. The other limitations in my view is the if we do 2 biopsies only, and if one of them or 2 of them come as positive, although from the criteria in terms of including the patient into active surveillance, they are less than 3 cores positive, but if you look at the proportion, there's 66% of the cores are positive. So it will be very difficult if we move to a targeted biopsies in future for patients for selection for the active surveillance. So a brief modified criteria, which I routinely practice in my day-to-day clinical scenarios: the PSA less than 10, PSA density less than 0.15 or 0.2, 3 positive cores maximum, then Gleason score usually between 3 plus 3. If it is 3 plus 4, then the maximum proportion of Gleason pattern 4 should be less than 10%. The clinical stage hasn't changed. Now addition is MRI lesion, which is less than 10 millimeter. What are the triggers for a treatment in terms of in patients who are on active surveillance? So the first one is upgrading of the Gleason score, without a doubt. If there is a great change, then they should be offered or discussed the radical treatment. If there is a large palpable nodule, again, they could have a repeat biopsies of that nodule to confirm there is a grade change, and then they'll go. If there is a rising PSA and progression of a disease on MRI, and on the other hand, there's psychological impact on the patients as well, which make the patient to change their treatment plan because they are finding it difficult to maintain on the active surveillance pathway. So what is the evidence? So this is the recently published in European Urology, John Hopkins 20-year follow-up. What they have done is the database, what they had of all the active surveillance group patients, they have subdivided them into grade group 1, 2, 3, and this is the all-cause mortality. If you see, it's at 20 years is 0.2. If you see for the prostate cancer, mortality or metastasis is almost unchanged at 15 to 20 years. If you compare that, the subclassification into grade group less than 1, grade group 1, grade group 2 and 3, again, they show that grade group 2 and 3, if they were subdivided initially, the prostate cancer mortality is quite high and progression. So if we identify the patients who put onto active surveillance at the start, the chance of failure will be significantly lower. Then this is the intermediate outcomes for very low volume and intermediate high risk prostate cancer managed with active surveillance, which again emphasizes that grade group 1 patients are better monitored and the chance of failure is less. So before we put someone on active surveillance, it is finding the wolf in the sheep's clothing. This is more important to find out and identify the high risk group patients, separate them from a low risk, and then the chance of failure would be low. Misclassification of the occult high-grade cancers can happen in 25 to 30% of patients, and biological grade progression over time is usually for these grade group 1 is 1 to 2% per year. Then again, how are we going to manage patients during active surveillance? Along with the the regular PSA and all, they need a quite significant input in terms of their psychological well-being. The other health, what we do routinely discuss with them is stop smoking, regular exercise, because if they need treatment, they are ready to have treatment with the least side effects or the complications. There is some talk about adding metformin, which is one of the treatment arms in the current prostate cancer trials. Adding the statin is again another pattern to maintain the cancer at that level or get them ready for surgery or radiotherapy if needed. This was one of the landmark trial, Protect trial, which compared the active surveillance, or what I could say is more of an active monitoring, because these patients didn't follow a strict protocol as active surveillance as we routinely use for our patients. It was a more of active monitoring versus the radical treatment, wherein there was a big number of patients, nearly 228,000 patients were involved, over 100,000 were included in the biopsy. And at the end, if you see, there's 545 equal cohort in each group, around 500 patients. 77% of the patients were Gleason 6. So it is not a cohort of all the different grades. It's mainly of a low risk and intermediate group of patients, where the 90% of the patients had a PSA of less than 10, 60% fulfilled the low risk criteria. So what we could say that although it concluded that there was no significant difference between surgery, active monitoring, and radiotherapy, but we have to take it with a pinch of salt that majority of this cohort had a low risk cancers, and that's why they may not have had a much benefit from the surgery. But this is a good example that active monitoring in low risk patients can have a very little impact on their overall survival. Now, also we need to look at the effects of survival and the disease progression at 10 years from this data. 98 out of 100 patients were alive at the end of active surveillance protocol, and this with the surgery and radiotherapy was a little bit higher, but there is marginal difference. If you look at the disease progression, the active only 21 didn't have a disease progression out of 100 patients. Sign of disease progression was around 21 out of 100 in active surveillance. On the other hand, 8 in surgery and radiotherapy. When you look at the development of distant metastasis, again, slightly higher, but there's still there was no significant difference. It was similar, more or less similar, or a little higher than the radical treatment options. This is the patient-reported outcomes, what happened during their monitoring process with regard to their quality of life. There was no difference in their quality of life. This suggests that they could be monitored well during this time. What about the urinary incontinence? If you can see, radical prostatectomy, there was a significant worsening of the urinary symptoms, and then there is a steady improvement at the end. Again, but this has to be taken into account that majority were open surgery and a few had only robotic surgery at that moment. If you concentrate on the active monitoring arm, that is more or less similar to the radiotherapy arm. Coming to the erectile dysfunction, active monitoring there was slight decline, but that is accepted along with the age of the patients. And in terms of, again, urinary functions, if you look at the numbers itself, at 6 months, problems reported were around 39 out of 100 patients in active surveillance, compared to 71 out of 100 in radical prostatectomy and 38 out of 100 in the radical radiotherapy. But if you look at the erectile dysfunction, that is more or less the same between the radiotherapy and active surveillance, but the robotic prostatectomy, that was around 20% more. In conclusion, I think active surveillance to be offered care in a carefully selected low risk or a favorable risk prostate cancers. To avoid the failure, I think it is important that we carefully select them before and stratify them and use various armamentarium from biopsy technique, the grade of the cancer, the MRI images, all the other parameters, what is available. We know that the Gleason pattern 3 is non-metastasizing and it lacks the like high risk hallmarks of the cancer. If there is a high volume Gleason 6 cancer, again, that may have to be used with a bit of caveat into active surveillance because there is worry that they may have a coexistent higher grade cancers. If they do have a Gleason 4 cancer, there is a increased risk of metastasis at 15 years. Recently, there is an involvement of MRI and biomarkers, which might significantly change our the active surveillance criteria and how we manage them in future. I think further risk stratification is essential as we are moving more towards targeted biopsies, and hopefully the nomograms and the biomarkers and MRI will help us to make this life a bit more easier.